Welcome to the Explainer. Today, we're diving straight into the next installment of our 50-state series on the CMS Rural Health Transformation Program. And this time, we're focusing on Iowa. We're going to bypass the broad federal overview and get right into the nuts and bolts of how Iowa differentiates its implementation. We'll be mapping their state-generated project and budget narratives right against the CMS post-award guidelines, specifically zooming in on that March 2026 post-award FAQ, so we can see exactly how they structure their localized procurement strategies.
Here's our roadmap for this breakdown. We're going to walk through the Healthy Hometowns framework, dig into the Hometown Connections hub and spoke network, check out the physical co-location strategies under communities of care, look at the technology integration, and then, well, we'll follow the money to see how their budget actually aligns with those federal technical scoring factors.
Okay, Section 1, the Healthy Hometowns framework. Let's look at the macro-level blueprint guiding Iowa's whole strategy here. Pulling straight from the state-generated project narratives in the 50-state spotlight document, Iowa's operating under three very specific primary goals. To meet those federal CMS expectations, they have to simultaneously build access points at the right locations using strategic partnerships, get those rural mortality and morbidity outcomes to actually align with urban centers, and build out the local data pipelines needed to monitor the whole system. It's a heavy lift for sure.
Now, the core mechanic of Iowa's plan relies heavily on legally formalizing these relationships. They're contractually binding smaller, local spoke clinics to larger, well-resourced hub agencies. The goal? Transitioning to a highly coordinated model. This matters operationally because it's specifically designed to keep care local. In theory, this reduces the need to transport patients to urban centers, cuts down on long hospital stays, and directly answers the CMS directive to stabilize rural delivery systems. Moving into Section 2, Hometown Connections. Let's see how that hub and spoke model actually translates into the state's largest specific initiative. We get a really clear operational contrast when we examine the state's maternal health hub procurement requests. A statewide hub is contractually obligated to provide 24/7 emergency support and provider-to-provider teleconsultation. Basically, they're there to back up less experienced rural providers. Spokes, on the other hand, are strictly designated for low-risk pregnancies. They operate under these formalized legal agreements where they literally have to refer higher-risk cases right back up the chain to the hubs. What's really notable about this is the highly compressed schedule Iowa is using to execute the framework. Taking a look at the timeline from the best and brightest medical equipment procurement RFP, the process goes from issuing the initial document on December 8, 2025, to having contracts fully executed by February 15, 2026. That is essentially a 2-month window. It's a very accelerated procurement strategy requiring the rapid formalization of legal partnerships and the immediate allocation of funds to get major equipment installed across these new networks. That brings us to Section 3, the Communities of Care Initiative. This component is structurally designed to transform rural service delivery specifically to combat chronic diseases. The mechanical steps for this pilot program are pretty straightforward. The state has to fund up to 7 geographically dispersed sites across rural counties. The structural mandate here is physical co-location. This means you've got to have at least 3 distinct provider types operating out of a single physical building. The whole idea is to completely remove geographical barriers for the patient. Plus, they mandate the employment of a community health worker to act as a system navigator. So a rural patient showing up for a behavioral health visit can be seamlessly walked over to an oral health provider in the same building on the exact same day. Up next is Section 4, Technology and Mobile Health. Let's examine how this physical infrastructure integrates with digital requirements. A strict compliance factor for grantees across all these rural initiatives is mandatory participation in the state's Health Information Exchange, or HIE. This is actually Iowa's direct answer to the CMS requirement for modernized data infrastructure that we saw outlined in the post-award FAQ. It's how they ensure continuity of care. The goal is to have patient records accurately follow an individual, whether they're moving from a rural spoke up to a specialized hub or just down the hall between co-located providers. Mobile care operations are also expanding to bring services right into patient homes. But rather than asking for federal funds to buy entirely new fleets, Iowa's budget narrative opts to retrofit existing rural ambulances with specialized gear for high-risk obstetric and neonatal transport. On top of that, by upskilling their current EMS clinicians through the Mobile Integrated Health Program to handle in-home chronic disease management, the state is heavily leveraging its existing workforce to cut down on avoidable emergency department visits. Finally, Section 5, Budget and Federal Alignment. We're going to track the financial arc to understand exactly how Iowa's resource allocation maps back to CMS expectations. Digging into Iowa's formal budget narrative, they are requesting an exact total of $1,009,040,000 and $73.71. This billion-dollar figure is the total federal investment required to actually execute the statewide structural overhaul over the course of the mandated 5-year grant period. When we break down the proportional distribution of that billion-dollar budget, you immediately see a massive financial reliance on the Hometown Connections initiative. It commands over 52% of the total funding. This tells us that Iowa's primary operational focus is unequivocally the establishment of those hub-and-spoke networks. They are pouring the majority of their resources into formalizing provider partnerships, buying the required equipment, and funding the workforce recruitment needed to actually make those connections viable. Mapping Iowa's primary initiatives directly against the CMS technical scoring factors demonstrates their structural compliance with the federal mandate. Hometown Connections is perfectly designed to answer factor C.1, which is Rural Provider Strategic Partnerships, along with F.1, Remote Care Services. Meanwhile, the Communities of Care co-location strategy directly answers B.1, Population Health Clinical Infrastructure. It's a clear illustration of how the state explicitly aligns its localized procurement strategy with the overarching requirements of the federal grant. We'll wrap up this explainer by asking you to consider the long-term mechanical reality of this blueprint. The state actually mandates that applicants develop cost-sharing and reimbursement models so they can operate without government funds by the end of the 5-year grant period. But the big question remains, can an architecture built so heavily on competitive procurement, formalized legal agreements, and newly outfitted networks genuinely financially sustain itself once that federal funding dries up? It's a question every single state in this series will ultimately have to answer.